Okay, good afternoon. Thank you very much to everybody for joining us today. We really appreciate you taking the time to ask questions and hear more about our plans for the next 12 months. So yeah, this session is all about how we're planning to deliver your health services in the Aneurin-Bevan University Health Board area over the next year. The discussion comes at a good time because it sort of dovetails with the release of our annual plan for the next 12 months, which our experts will tell you about going forward. So I'll just ask each of them to introduce themselves briefly, if that's okay. So Nicola, come to you first.
Prynawn da, everybody. I'm Nicola Bregodic. I'm the Executive Director of Planning, Digital and IT for the Health Board.
And Chris.
Hi, I'm Chris Dawson-Morris and I'm Assistant Director of Planning here in the Health Board.
And last but not least, Kath.
Yeah, thanks, James. Hello there. My name is Kath Smith and I'm Associate Director of Ops here in the Health Board, Operational Delivery.
Okay, brilliant. I haven't forgotten anyone, have I, Amy? Okay, great. I know some people don't have their screens on, so just checking I haven't left anyone out. I should have mentioned at the start as well, you're very entitled to ask any questions that you'd like to ask in the through the medium of Welsh. You can either do that verbally again, or you can use the message chat box, and we will get our answers translated for you and then put back into the chat box. So diolch yn fawr. So yeah, let's get started with this virtual Q&A. It's obviously been a little bit disappointing that we haven't been able to meet or do any engagement sessions in person during the pandemic. But I hope that you'll find this session really useful. And if I can just hand over to Nicola to begin, that would be great. Over to you, Nicola.
Okay, thanks, James, and welcome everyone. It is lovely to see so many people interested in coming to hear about the plan, and we're really pleased for you to join us today. The structure of the session is I was going to just give a brief overview of planning in the NHS for those people who might not be as familiar with what some of the expectations are. And then I'm going to hand over to Chris Dawson-Morris, who's going to go through a fairly short, succinct presentation on our plan for this year, take us through a little bit more of the key themes and some of the assumptions. And then really leave it open for a question and answer session to give you all the opportunity to ask questions about the plan or anything really, because the whole purpose of the plan for the Health Board is it encapsulates everything. So we will do our best to answer as many questions as we can, and anything that we can't answer, Amy will be capturing them anyway, and we will follow them up with a response in due course. So if everybody's happy with that as an approach, I'll work on that basis, and Kath, myself and Chris will do our best to respond to all our questions. I said that's why Kath's here to help us with any really difficult one, who's on the ground delivering on a day-to-day basis. So just in terms for those who are not familiar, when health boards were formed back in 2009, we went in very much into a planning system in the NHS in Wales, different to some of the kind of market type structure in England at the time, and producing integrated medium-term plans became a statutory obligation of health boards, where they had to set out for a 3-year period what their plans were in terms of their service priorities, their workforce assumptions, their financial assumptions, and really try to encapsulate the whole agenda right from the prevention responsibilities, public health, through to primary care community services, as well as secondary care services and responsibility for most kind of tertiary regional services, and even those specialists such as things that people may need to go to England. So we needed to encapsulate the whole of our portfolio of responsibilities. And even though they were 3-year plans, you had to update them every year. So it was a rolling 3-year plan. So this is something that we've all been working really hard on in Wales, is trying to improve our planning. We've tried to move away from big 300-page documents, which tries to cover everything, into a very more high-level kind of story around where the organisation has been, where it's going, and its plans for the future, and should always be set in the context of their overarching strategy, which in Gwent was well established with our Clinical Futures strategy. I am pleased that we've, as a health board, have had an approved integrated medium-term plan by Welsh Government every year for the last number of years. Not many health boards have not managed to achieve that, often due to some of the financial challenges or some of that lack of strategic context. But we have had an approved integrated medium-term plan in Gwent, which is really positive. And I think every year we've taken the opportunity to try to improve that and how we share and communicate it with our public. Obviously, during the pandemic last year, we produced our 3-year plan by January 2020. But obviously, as we hit the pandemic hit us, all of the IMTP process was paused. I am going to say IMTP because that's the shortened abbreviation for the integrated medium-term plan. So that process was paused, and we went into a quarterly planning cycle last year. So we were required then to produce a plan just for the quarter ahead, and then we did it for 2 quarters at the end of last year. Recognising the stages of the pandemic, we were then asked going into 2021-22 that we produced an annual plan. So again, they didn't expect us to do a 3-year plan, recognising we were still facing many uncertainties. And I've asked all organisations to produce an annual plan for the year ahead. And that's what we're going to take you through today. It obviously is very much set in the context of our ongoing strategy. And we also have taken the opportunity to take a bit of a refreshed approach and try and kind of think about it through a slightly different lens. And that's what we're quite keen to share with you today. So that's kind of the context of planning in the NHS. It obviously is an iterative process and something that we are, Welsh Government very much give us the guidance on this. And we've already submitted a plan back at the end of March, which Welsh Government have given us some generally very positive feedback, and all organisations are now expected to submit a new plan, a final plan by the end of this month, at the end of June. So really, if there's anything changed in the last few months, any further information we've managed to gather, then there's an ability to resubmit the plan. And Chris will take you through ours, which is pretty much set as it was at the end of March, because we had a lot of confidence in it, and just send in some support in detail. So I'm not going to say any more than that. Hopefully that's the helpful context, and I'm going to hand over to Chris, who will take you into the plan in a bit more detail and the priorities for this year. Thank you, Chris.
Okay, thanks, Nicola. I'm going to share my screen now. I've got a few slides to show which will help me helpfully illustrate as we go through, and hopefully this won't be, it's definitely not intended to be lots and lots of PowerPoint, but just a few prompts to hopefully help us as we take through this part. Now, I do have a tendency to get overexcited when I'm presenting and waffle on for ages, so I'll make sure that James keeps me to time in a short, tight presentation on this, so that you've got plenty of time to ask us questions, which is the most important point. So Nicola's described sort of the context and why we're producing this annual plan, but also described the fact that as a large organisation that covers a huge number of areas, how do we keep focus as an organisation on the right thing, and how do we make sure that we have a clear and overarching goal and approach as an organisation into what we're trying to achieve? And is it possible, when we have work that happens right through from our communities and the work that we do in primary care and in people's homes through to high acute care and hospital, to have that single overarching focus? So what we try to do as an organisation, about thinking about what is it that's that really important focus for us as an organisation. And we've described the really important work that we need to do around tackling health inequalities across our patch and across our health board population, recognising that particular challenge that we have an 18-year gap in healthy life expectancy between our most least deprived communities and our wealthiest communities. Now, we don't think that's acceptable as a health board, and we don't think it's acceptable for our communities to have that gap in healthy life expectancy. And it gives us a driver and focus for our decision making and our priorities and the actions that we take as an organisation, that we know we need to reduce that gap in healthy life expectancy. And we also know, sadly, that's a gap that will have been exacerbated by the last year we've had in the pandemic. We know that COVID didn't hit people unequally and affected our poorest communities in the worst ways. So we know actually there's a challenge that gap in healthy life expectancy is most likely to have increased during the last year. So we want to use that focus as an organisation to help us in the prioritising and the decisions that we have to make as an organisation over the next year as that overarching focus. So the question then comes, well, if that's quite a broad overarching focus, how do you then identify core pieces of work and the core actions that we want to take as an organisation in the next year against that overarching theme of reducing health inequality? So what we've tried to do is think about a life course approach, to think about each of the stages of life that we life and well-being that we support across someone's life, and the interventions that we make in someone's life as they move in and out of our services, and hopefully to keep people well in the community. So we've tried to structure our priorities around that broad life course approach that allows us then to think about people in the round, not think about individual bits of services, but think about how they come together in their broadest sense and how we support people in the round. And that's the sort of blue circles that you can see in this diagram here. Around the edge, then you have what we call our enablers. So what are the things that we need to do as an organisation to support those priorities? And I'll talk a bit more detail about each of those priorities now. So you can see there that first priority that we've identified in our annual plan is about giving every child the best start in life. And that's quite a high level statement. And it's about recognising that we really want to support those early childhood experiences, supporting women through pregnancy and supporting people to get that good start in life, because we know that has a significant impact on people's well-being and their health through their young adult lives and into adulthood. And so we know we need to focus on those areas. So we've identified here a number of pieces of work that we're going to focus on over the next year to support us in that ambition of giving every child the best start in life. So there's work that we need to do in supporting women through pregnancy, and we've targeted particularly some risk factors there. Again, that links back to our focus on tackling health inequalities, because we know there is challenges around smoking and pregnancy, and the challenges that we have around healthy pregnancies are most challenged in our most deprived communities. So we know it helps us if we can get it right for these women at this part in their life, that we can help and impact on our overarching aim and really focus. We also have that focus then on supporting around adverse childhood experiences, so reducing harm and antisocial behaviour, and working particularly in partnership with local authorities and others on that area, as well as then really important focus on immunisation. And we've learned particularly over the last year about the importance of vaccine and immunisation as a preventative health measure. And we know, for example, that through the pandemic, lots of our school nursing were redeployed to help with testing, to help with vaccination, and to help with other areas of work. And actually, we know that in the next year, we need to focus back on that, supporting children in schools and running those successful immunisation programmes to prevent health impacts on our children as we go forward. So these are the pieces of work that we tried to identify to support us in that priority around giving every child the best start in life. We then think about that children and young adult category, and how do we help children and young adults to make that transition through from being children into adulthood, and what's the role that we play as a health service and as a health board in supporting this population. So we've got a really important programme around called Iceberg, which is about supporting young adult mental health and children's mental health and resilience. And it's about how we make those early interventions in supporting people's well-being and supporting childhood well-being and supporting adult mental health well-being. If we think again about our challenge of focusing on health inequality and what's happened through the last year, we know there's been disproportionate effects on our young adult population. It's those that have been left out of work, that have had their education significantly disrupted, and are likely to have the long-lasting effects of unemployment, potentially as a consequence of the economic impacts of the pandemic. So that we know that we need to get right our early intervention and well-being programs for young people, so that we can build that resilience in our communities and get those early interventions and those community supports that stop people then falling into our services, into our higher needs services later on. We know as now we need to focus on that healthy weight and supporting children to live well. We know these are the years when we can make the biggest impact on people's lives, and if you can get people in their young years to make those healthy choices, and also we support through our community programs to help people to do that, we know we can support them as they move into adulthood. And we know, as we've learned from the pandemic, it's really important to get those healthy impacts right and make those interventions early. Importantly, the last one identified there around that transition pathway for children moving into adult services, we know that is often where the gap in services happen as people move from children's services into adult services. So we really want, and particularly around our mental health services, so we're really focusing this year on that pathway of people moving through from child into adult services, that we get that pathway right, that we focus on the early intervention, and we get it right for those that category of people who have been so affected by the pandemic in the last year. We finally move on. We move on thirdly then to our supporting adults in Gwent to live that healthy and ageing well. And this is mostly about our working age population. And there's a significant number of things and here and actions that we've identified around this population, where we want to support adults to live well and live healthy, live well and age well within our populations and retain that independence as much as possible. And we've identified sort of 3 core areas there. One is about making the most of people's time. Time is a really important currency. We want people to be well in the community. We don't want people to have to spend their time in our services, in our hospitals and other areas. We want to keep people well where they live and to be able to play active roles in their communities. So we've really focused on some key pieces of work there around outpatient transformation. So that's thinking about actually how do we deliver outpatient clinics? So if you need to come in and see someone face to face, how are we doing that in our community? How are we doing it virtually so that people don't have to travel? And where someone may have to travel for it, how do we shorten that journey to do it locally? But also, how do we make sure that we're not wasting people's times? I'm sure we've all got experiences of where we've been asked to turn up for a follow-up 6 months after something, only to be told by the consultant, oh, you're fine, I didn't really need to see you. And then the fact is you've taken 2 buses to get there. It's taken you a long time. You've struggled to get there and you've waited for that appointment only to spend 5 minutes being told you're fine, I don't need to see you again. So how do we get rid of that unnecessary follow-up and thinking about how we change the way we do outpatients? Importantly as well, we've identified a number of focused pathways to work on. So MSK is the musculoskeletal system. So we're thinking about how do we get it right for that pathway right for people who have MSK problems, where we can support people again in those early interventions and looking at alternative pathways, again focused on our respiratory pathways. So how do we get that focus right on people with respiratory conditions to support them to live well in the community? And again, thinking about our eye care pathways as a particular focus. We know there has been challenges in getting people to see their optician to get those regular eye checks, and we know we've increased our waiting list of people waiting for things like cataracts. So how do we have that focused pathway work and focus on those priority areas to support people in those focus? And I think also recognizing in this about that living and healthily and aging well, recognizing that we can't simply focus on the activity around recovery and restoring services post the pandemic, but we equally must do that preventative work. And we know that we need to do that work around supporting people to do well, those health checks, those early interventions, that we support people in those positive behaviours. And that's why we've identified as a priority within the plan. And with this ambition of supporting people to live well, to think equally about our preventative programmes. The final priority we got there is about maximising cancer outcomes. We know we need to improve our cancer outcomes and have a particular focus on there. We know 1 in 2 of us will be affected by cancer at some point in our lifetime. So making sure we've got a real focus there about actually how do we get that early intervention and those diagnostics right, and setting up things like vague diagnostic clinics where people can come in, get their diagnostics in one go and get a clear response, as well as thinking about how do we work in partnership with Velindre and others around developing new services such as the satellite radiotherapy unit up at Neville Hall, and redesigning our systematic cancer therapy, which is effectively chemotherapy, to put it in plain English. So how do we get those services in the right place? The fourth priority then is about providing high quality care and support to older adults. And this is about focusing on aging well and not focusing and really about focusing on the right things for our older population. which is really about actually how do we keep people well in their community? How do we use the networks that are available to us to support early intervention, to get that anticipatory care, to get our community services right, to support people where they live, to build that support for carers and that support for those who look after our older population, so we can keep people at home and keep people and anticipate needs, because we know we don't want people to trip into our system, and we want to keep people as well as possible, because we know that's just simply good healthcare. It's good for individuals, and we've got to focus on those areas. So we've got a number of programs working particularly in partnership with local authority partners around how we keep people well in the community, as well as then thinking about, people will need to come into our services. Well, how do we get that rapid flow through so we're not keeping people in the hospital system? We know that people in a hospital bed deteriorate and lose function, and we don't want people to be sitting in our hospital beds. We want them to be in their homes, in their communities, and with their loved ones, and supported in the right place. So we're doing a lot of work thinking about the flow and the pathways that we have for our older population, so they can come in, be seen in a quick way, and be supported through schemes such as our Home First scheme and our Discharge to Assess programs, which is where we look at getting people out of hospital as quickly as possible. So the final priority there is about dying well as part of life and providing high quality end of life care to our population. We really know, and we've really learned and seen over the last year, those particular challenges around supporting people at the end of life and providing good end of life care. It has been pretty horrible for some of our staff to not be able to have to be there with people at the end of life and not have family around them, and not be in that period where we couldn't have hospital visitors in, was a real challenge. And we don't want that for our population. We want people to have a really good end of life experience, because we know the legacy that has for families and others. So we're really focused on supporting people in advanced care planning, in thinking about the education, support and bereavement offer that we have for our population, and really thinking about effective care for ensuring that a good death and good end of life care happens for our population. So I've kind of whizzed through the 5 priority areas there and some of the work that we're focused on, I guess, and I'm conscious I'm waffling on here, so and I want to make sure we've got plenty of time for questions. But just to touch on, so how do we support those things to happen as an organisation? And I've entered into some of the enablers here. One is about making sure our estate is focused and then we've got the right buildings, thinking about how we finance the right things, thinking about making sure that our research, innovation are focused on the right areas and supporting those priorities. But I think I'd really highlight the work around partnership first. So we're trying to adopt an ethos that in setting our priorities and working, that our starting point is always partnership. It's about working with local authorities, working with the third sector, working with community groups, that when we're thinking about the changes that we want to make and the actions we want to take as a health board, our starting point is working in partnership. We know that we can't improve services for our older population without working with the care sector, without working with local authorities, without working with the third sector. So always maintain that partnership first ethos for us as an organisation, as well as thinking about then digital transformation. So how are we making the most of the tools that are available to us, and making the most of such as the switch to virtual appointments, such as the switch to remote monitoring of patients, and how we're maximising where it's appropriate those digital tools. And then I'll just finally mention that work around data and intelligence. We want to be an intelligence-led organisation. We want all of our decision making to be supported and backed up by good information. So we're putting a lot of effort and work in as an organisation to really focus on how we use data and information as an organisation, and how do we make sure we've got intelligence-led decision making. So my final slide, you'll be pleased to know, I just thought I'd touch on a bit about recovery planning. So we do recognise the challenges that the last year has brought in terms of the challenges for backlogs of demand that have built up. And I think, as I've talked about the priorities there, all of those things will support us in building sustainable services and help us in our recovery, and focusing not just on how we build sustainable services, but how do we make the changes needed to support our community in recovery. But I thought I'd just touch briefly on 1 or 2 areas just to let you know what's happening really. So in terms of our recovery planning, we're taking a risk-based approach. So what this means is we're looking at those who are on our waiting list and those who potentially might come onto our waiting list. So those what we're calling unmet demand. So people who didn't come forward in the last year but probably should have come forward. We're building getting a number of those people and thinking about, in terms of their priority category, do we understand the risk to them as individuals of having their treatment or not having their treatment, and categorising our waiting list using a prioritisation framework designed by the Royal College of Surgeons, so we can understand the risks to treatments to individual, and that therefore we'll be able to pull people through associated to their risk to that individual, not simply looking at a time-based measure. We're also trying to make as many COVID safe environments as we can. So looking at how do we maximise our estate to create safe spaces for us to work in and deliver planned care activity as much as possible. So that's about zoning our hospitals effectively to make the most use of all of our capacity. And that's, again, as I've sort of duplicated the point there, around maximising our capacity, so making sure that we're getting our workforce numbers up and that we are making use of our estate so we can pull people through and trying to recover some of that activity. But importantly as well, it's about thinking about alternative treatment pathways. We know there is a significant amount of demand out there for our services, and a growing demand, and we've got to think carefully and creatively about how do we get the right people to the right service. So where we've got someone that talked about the musculoskeletal conditions earlier, actually are there appropriate treatments that can be therapies led or led by a physio rather than a surgical intervention that might be appropriate for some cohorts of into people. So how do we think about the right treatment pathway for people, not simply about pushing people through a process quickly and trying to recover our backlog, but making sure we're getting the right treatment pathway for individuals. So that's the work we're doing around recovery planning. And I think you're pleased to know that's my last slide. Apologies, that was a lot of information in one go and lots of talking, but really keen to open it up for discussion.
Okay, thank you, Chris. I think you did very well personally to get such a long plan into 10-15 minutes of talking. Was an excellent effort, and thanks to Nicola as well for her thoughts. So we've already had a few questions in the chat bar, which is great. Feel free to put your questions in there, or if anyone would like to put their hand up as well, then I'll try and take those in the order that they come in. So if we start with a question from Julie, can you tell me when the NHS retinopathy system will start, please?
Do you want me to take that one, James?
Kath, can you?
Yeah, sure. Yeah, absolutely. It has started. It's already restarted, but there's a massive backlog, as you'd expect. So there is a delay in appointments. I'm not quite sure what the wait is currently, but I'll try and find out before the end of this call what the current wait is, but it has restarted.
Okay, thank you, Kath. And also from Julie, a friend lives in Paris but has care from the Grange University Hospital. How would he receive end-of-life care? Picking up on your point from the presentation, I believe, Chris, that came in. Who'd like to answer that one?
Do you want me, I'll pick it up broadly, and then if Kath or Chris want to come in. So, so there's a couple of things that we're trying to do as part of end-of-life care. Some of this is working with families early on in their illnesses to understand people's kind of personal preferences and respect some of their wishes when they could be faced with an end-of-life situation. And that's very much done through our primary care teams and our local teams, and therefore Powys primary care teams, which are potentially working on the same issues. We then obviously, when people enter our kind of hospital system, we would then obviously often check at that point that we understand those family wishes, and if they got an advanced care plan from previous or try to understand. So if a Powys patient comes into our hospital, they absolutely will be treated in the same way. And in terms of how we would manage their end-of-life care, if it's with our own staff and our own teams, would be absolutely consistent. What we would do is, if we were then handing their care back over to the local district nursing teams or other healthcare professionals, we would do our best to make sure that we, that all of the paperwork and the records and that communication is shared with those local teams for the Powys kind of community teams to be able to respect the wishes of the team. So if it's in the hospital, it'd be absolutely consistent. If we're handing over to Powys workforce, we would just ensure the communication was working effectively. Anything you want to add to that, Kath, that I might not cited on the ground? But
no, absolutely, that's absolutely the pathway that would follow. We, close links with our, GP colleagues, primary care colleagues, and district nursing colleagues, and as you say, communication is key to that. So, yeah, absolutely right, Nick.
Okay, thank you both. I can see Kevin has asked a question in the chat bar, but he's also got his hand up. Kevin, would you like to ask the question or a couple of questions?
There's two points, please. And James, please stop me if I ramble on. The first question really is for Nicola and Chris regarding sort of mental health. Are you confident you have the adequate resources and partnership working and engagement with local authorities and voluntary sectors in regard mental health? And what Nicola said was that she's got lots of confidence in the plan at the end of March, which have gone to the Welsh Government, but there's an amended plan, I think she said end of June. Will there be huge focus on mental health? Because a number of queries I'm receiving are mental health. That's the first question. The second question is for Catherine, really, regarding sort of the operational matters and the health inequalities. In regard the resulting of the temporary withdrawal of some services, and I refer you to radiography, X-raying, GP patients to Ystrad Mynach, the Gwent and Neville Hall. I understand that there was less crowded in areas like the County Hospital, St Wallace, Chepstow and Ebbw Vale. And the X-ray, I understand GPs were telling their patients that they couldn't have appointments in Ystrad Mynach, and there would be a temporary hold. So when I actually raised this point, I was told that we can confirm that part of the Health Board's clinical future programmes, which are linked to establishing a new 24/7 laboratory service at the Grange University Hospital, and all this is included in the actual clinical futures document. So my questions are on that. It was temporary withdrawn. Can I have some dates and time scales when it will be put back? The justification: was there consultation with the public councils and stakeholders, and who made these decisions? Now, I don't expect answers, you can write to me, but residents are asking me these questions about, we can't have appointments in Ystrad Mynach, Councillor Etheridge, and we've been told we've got to go to Ebbw Vale, and I've got concerns. Sorry, I've gone on a bit, but
Okay.
Thank you.
Thanks, Kevin. Is it better to take the last question first, because that's probably fresher in our minds?
Yeah, that's fine. So if Kath wants to pick up that initially, and then Chris will pick up the mental health response.
Okay.
Sorry, Kevin, I'm not quite sure what. So are you talking about radiology clinic, radiology appointments in Ystrad Mynach, is it?
I'm talking about radiology, X-raying, and referring GPs not referring patients to Ystrad Vale because of X-rays, and I understand Royal Gwent and Neville Hall as well. And what has been said is, because there's less crowded at Panteg, St Wallace, Chepstow and Ebbw Vale, the actual radiography team are actually working out there, but it was only a temporary nature. A limited service would be resumed later this month. So I would be grateful if you could find out, if you could define, or somebody could define, when the service is coming back to them areas.
Okay, I don't have the answer to that now, but I'll certainly look into that one for you, Kevin, and I can get back to you. Not a problem. We'll make a note of those questions. Now we'll get back to you.
Thank you very much.
Can I just check, Kath, as from our understanding is there was X-ray provision at YYF, and there should still be X-ray provision at YYF. So maybe there was an issue for a period of time that Kath and I are obviously not cited on, because one of the things we did, and you referred to it around the Clinical Futures Plan, is we invested quite significantly in additional radiology staff, because we recognised we were putting lots of new kit into the Grange Hospital, and what we didn't want to do is then take that very important provision from the other hospitals to be able to staff the Grange. So, and we know there's huge demand for x-rays and CT scans, so we invested £2 million in additional radiology resource a couple of years ago to get them trained and recruited to be able to support a much more robust radiology service across the whole of Gwent, as you said. So that enables to us to still do x-rays in Royal Gwent, Neville Hall, YWF, as well as some of those community hospitals. So that's the plan for the Health Board. So we will take on board your queries and some of the concerns your residents have raised, and we'll find out what's happened and if there's anything that's happened that perhaps we weren't aware of, and we'll get back to you as soon as possible on that. But that's what our plans are, is not to reduce provision. Whether there was a period of time where there was some particular excess demand and we've tried to spread that out so people are not waiting. But as far as I'm concerned, there's no change in the service provision at YWF. But we will confirm your queries in case something's happened.
It may be specific films, Nick, or it may be specific images that are requested that can only be provided on one site, but certainly we'll look into it most definitely.
We'll get that clarity. And Chris, do you want to pick up the mental health?
Yeah, so on the mental health one, the question was about, do we feel that we've got adequate resources across and the partnership working in place to support our mental health programme? So I think in terms of the partnership working, I think that we're confident that we've got the right discussions that are happening with our partners in the third sector and with local authorities. They're very much part of the transformation work that we're undertaking around our mental health services. And as I described, the partnership first approach is really borne out in our work that we're undertaking in mental health. So we've got a number of change programmes that are happening with our mental health services, and many of our frontline providers are actually the third sector. So we're really confident we've got the right partnership working arrangements in place there and working across the other areas. And I'm sure you will have seen the engagement exercise that we undertook recently around the changes that we're making in terms of some of our mental health provision, and seen again then the real focus on partnership working. And in terms of the question around resources, we're working within the resources that we've got available to us and the budgets that we've got in terms of our service design. But we've also had the opportunity to, as part of Welsh Government funding that is available to support recovery, to put forward ideas for additional pieces of work to support recovery. And there is a particular focus from Welsh Government in those programmes around work, particularly for supporting mental health and particularly for supporting primary care programmes. So we know of the money that hasn't been a sort of formal write out yet from Welsh Government in terms of that funding, but we know there will be opportunities to pitch for additional resources, particularly for supporting improvement in mental health services over the next few years. So on that question, it's a question of using what we've got plus an opportunity to look at further Welsh Government funding.
Thank you, Christopher.
Can I just add to that, James? As Chris said, so there's a particular strong piece of work going on around the mental health, and almost the Clinical Futures Rainbow you might be familiar with is making sure that we are following all of that for mental health as well. And recently just completed, as some of you will probably be aware, a mental health engagement exercise with the public around the future plans for mental health, and particularly that partnership piece there of how do we work together to support individuals. So it's very much at the forefront of our planning going forward, and there's different projects in train for all parts of the system, right from mental health well-being right at the early stages up to specialist inpatient facilities for the future as well. So there's a huge amount of work going on, and mental health have done a sterling job over the last year of trying to keep their eye on the future direction as well as trying to respond to the here and now. And I think we're all concerned about the impact on individuals with mental health and the impact that could have on the service as a result of the pandemic. So it very is a strong feature of our plans and Welsh Governments, which will be helpful with the resources that potentially will be available to us.
Okay, thank you, Nick and Chris. We'll move on. Is that okay, Kevin?
Could I ask a question, please?
Of course, Howard. I can see you've got your hand up virtually and on the screen,
fine.
so please go ahead.
Could I ask if anybody is, any member of the Iron Bevan Health Board is going to reply to a question at a later date, that they send that response to each person who is on this this meeting, please?
So in terms of what we've answered as of today? is to
Well,
put
no, in case, in terms of if you were going to send a specific answer to a question, would you please send that response to everyone?
Yes, we will. Amy, that's reasonable, isn't it? That's what we'll do.
Thank you very much.
Well, thank you. That's important.
Okay.
Yes.
Thank you, Howard. Okay. On to the next question. There was also, I missed off one of your questions, Kevin. Perhaps we could answer this one quickly. Have we got a recovery plan for each hospital within the health board?
We haven't got a recovery plan as on a hospital basis. We very much have done recovery plans for a service. So if that service is running across a number of sites, then we will have done it for the service as a whole. But there will be a recovery plan for all services, encapsulating what's at every site. But you know, if that makes, so for example, if there's outpatients going on at Neville Hall, the Royal Gwent and YWF, as there would be, we would do an outpatient recovery plan for particular specialties rather than we just looking at dermatology on that site and not the others. So it's done very much at a service level, not at a site. Anything you want to add on that, Kath? Is that, you know, happy?
No, that's absolutely right. Thanks, Nick. Thank you.
Okay, thank you. On to a question from Dawn. Dawn has mentioned a shocking statistic that says people with learning disabilities are dying 25 years younger than the general population. What is the health board doing to reduce health inequalities and increase the life expectancy of people with learning disabilities?
Okay, so I can talk quite high level. We can get probably more detailed on the learning disability plan for you, but I know there's a significant amount of work that is being progressed by the Learning Disabilities Directorate. There's some work in particular over the last few years that has looked at kind of the model around how, you know, the circumstance with which people are living and how do we improve that, particularly looking at what we can offer them in terms of the life they live and the accommodation they live in and the service provision we give them, working with our local authority colleagues and others. So there's been a new model agreed over the last few years, which has been really well received and has had some excellent feedback. I think the other bit that Chris particularly referenced in the plan was around that transition. So that transition of children to adults, and I think this is particularly relevant for learning disabilities, where they move services and often really do see a change in the provision that's offered to them. And I think some of those, I haven't seen the statistics, but I know from experience elsewhere that you often see young adults, some of the, that higher levels then of death. So I think we do really need, that is an area of priority, but we can probably get a more comprehensive update for you on learning disabilities, unless Chris or Kath has got anything to add to what I've just said.
No, I think you've covered the main points there. I think there's a particular focus this year around that transition age group, and that making sure that we know there is people often fall in that gap and particularly for our learning disability population, that's a real pinch point in our service provision. So making sure we've got that consistency of care through that point is a big focus for the team this year.
Okay, thank you both. I'm conscious we've only got 15 minutes left, so I'm going to get through these questions as quickly as possible. Just a reminder before I get on to Michelle's question, if anybody would like to ask, I know you're writing questions in the comments box, which is great. I'm happy to read them out. But if anybody does want to ask their question in person, please also feel free to put the virtual hand up at the top of the screen. It's the little smiley face with the hand in the air. Okay, Michelle's question is thinking about accessing GP services, but it might apply elsewhere also. Many people struggle with using the phone or experience digital exclusion. How does this fit into your plans for the next 12 months, please?
Okay, so I can pick up the broader point. Sorry, can I just go back to the first? I was trying to read the question on the screen and I couldn't find it. So in terms of just picking up the digital inclusion piece, I think we recognise this is a huge issue for us to pick up, particularly in some of the communities and some of the age groups. So, and I know there's another question on the sidebar around volunteering, and this is an area in particular where we've been working with Digital Cymru, or where we've been working with schools as well about how we can try to link up some of our more digitally, people who are struggling with digital or haven't got access, and how we can work with them in terms of improving access, and also using children and school children to train them on how to use that and to get better access. And it's not just about the devices, it's also about coverage. So we've also been, we're also aware of parts of our community where signal is a particular problem, and working with working with the government on those particular areas. We've done quite a bit in the hospital, where we know where there's been some trouble with people communicating, and we've tried to put in additional digital devices into the hospital environment to support the nursing teams and patient liaison officers to be able to make sure people can communicate with their loved ones, especially while we've not had visitors. So that's been a particular area of focus as well. But I'm not about the GP services I might have missed. So
yeah, just to add, I guess. Sorry, I was just going to add on that one, Nicola, because there's particular work that's been done around, you'll have seen the work that's happening around Think 111 first, and encouraging people to phone 111 if they think they might need urgent care that's not immediately life-threatening. And we know as part of that work, we've done a lot of work working with third sector organisations and individuals on how we make that as accessible as possible. So making sure that we've got text phone services, text messaging services, and alternative ways of contacting for those who do struggle to use a phone. So we know we've got those services in place and those alternative methods for people to be able to contact.
Yeah, one thing just I picked, I'm sorry, I can see the message now. I got the context a bit better. So one of the things I picked up recently on one of the Community Health Council calls is, the requirement where maybe the GP says, can you send a photograph in? And people are really struggling to do that. And that works brilliantly in some cases, but, I know some of the communities were really struggling with that. And we are picking that up as part of our primary care discussions, is that face-to-face contact, and not that, the new virtual approach doesn't suit everybody. So we are making sure we support and encourage GP practices to recognise that and respond and meet some of the local needs, particularly around those digital challenges that some people have.
Okay, thank you. What might go well with that question as well is, I know myself and Amy have seen in the communications and engagement team a lot of questions coming in about people struggling to access a GP appointment. Can you give us an update on how that might improve over the next year?
Chris, do you wanna?
Yeah. So there's lots of work happening in this area with our primary care team around how do we support access to the right service first time in primary care, and whether that's a GP appointment or whether that's actually support from an alternative healthcare provider. So where I mentioned sort of the MS musculoskeletal work earlier, actually if someone rings their GP with a problem that's more suited to seeing a physiotherapy first or physiotherapy practitioner first, we're putting in support to ensure that we've got first point of access physio. We're also looking at first point of access mental health services within primary care. That allows then, for where it's appropriate for people to see alternatives to a GP, to be able to free up some of our general practitioner time to be able to get those appointments through, as well as then continuing to roll out the work around those technological changes for where it's appropriate. That's those switches to virtual appointments, those use of the systems where people can take a photo and send something in. Actually, those can be quicker ways of getting access to GP advice for appropriate people, for appropriate patients. That does free up that time, hopefully, to make it easier for others to get appointments.
Okay, thank you, Chris. Move on quickly to a question from Marion. Marion said, averaged out, how much longer are waiting lists for elective surgery now than prior to the start of the pandemic? Can we give Marion any sort of rough estimate on that?
Yeah, I guess Kath may have more information, but I guess I think this comes back to the sort of taking a risk-based approach as opposed to a time-based approach. So it's probably difficult to give a specific answer, as it will depend based on the condition and based on the individual circumstances and the categorization of that patient. But we know that those who are most at risk and in those urgent, what we call risk categories 1 and 2 under the Royal College of Surgeons prioritisation framework, we're actually seeing a reasonable time frame. But where we are seeing those longer waitings, it is for those in those different risk category of patients. That is not to say if you are someone who is living with pain and living with discomfort that your need isn't urgent or important for you as an individual, but it's how we take that risk-based approach to care. I'm sure Kath will want to add to that.
Yeah, thanks, Chris. Appreciate that. And I can't actually remember where we were pre-pandemic now, but the waiting list was in a much healthier position and probably one of the better positions been in for a very long time, apart from the very specialised orthopaedic surgery that we were managing locally. The position now is not where we want it to be, but obviously, that was sort of out of our control in terms of the pandemic, and we've got far too many patients now waiting a long time to have their surgery. But as Chris has said, it is a risk-based approach to managing that, and those patients that require their surgery urgently for life, limb, or anything emergency surgery is being treated in priority order. But as I say, we've got way in excess of about 36,000 patients waiting over 36 weeks at the moment.
Okay, thank you. I've just got one more question from Marion, and then we'll go over to Julie, who I can see is waiting patiently with her hand up. So what are the plans for the use of space at Neville Hall Hospital following the move of many services to the Grange University Hospital, other than the new build radiotherapy centre?
Can we cover that?
Yes, please, Nick.
Yeah, so we've got some clear plans really for Neville Hall and the Royal Gwent going forward, although we are constantly checking and testing those now in the context of being able to still respond to the pandemic and also the recovery challenge we've got. Neville Hall has got a fairly clear plan with most of its space utilised. As you mentioned, there's plans for the new radiotherapy centre. We're also planning to develop our in-house cancer services around chemotherapy in 2 of the ward areas. So we'll have what we call a local cancer centre, and we're in the middle of putting a business case together for that. We're also looking at how we could use the Llanwenoth suite there, which was the day surgery, which has now been moved into the main building. We are looking at that, as is there a potential to use that for additional cataract facility, and we're working with our regional colleagues around that as well. And another key project up there is about how do we expand our day surgery capacity at Neville Hall, because as you said, there are still a few empty theatres that we're not using. Our biggest constraint is workforce, so we've now got quite a lot more flexibility across the sites in terms of physical space, which is really good and has saved our lives really through the pandemic, being able to spread out into greater space where we needed to. But workforce is what we are currently is our biggest challenge in being able to utilise all of that physical capacity. But we have pretty much got a plan for Neville Hall, which shows how, apart from a few areas which gives us some future flexibility, we will be using that space. And as I said, the day surgery and cataracts in Llanwenoth are 2 projects that are currently in progress. So that's the Neville Hall plans. You're on mute,
James.
Apologies. That always happens, doesn't it? I was just going to say, Julie, would you like to come in now with your question?
Yes, I put it in the chat as well. But is there a link service between Neville Hall and the Grange? Because if there's a service that's been transferred to the Grange from Neville Hall, for instance, it means that I've got at least 3 buses to get to the Grange, and that's if they're linked together, and then 3 buses on a return journey. So is it possible there could be a link bus between Neville Hall and the Grange and then back again? For people who haven't got their own transport now, I'm thinking, which is myself.
Thanks, Julie. And public transport in particular has been a very important topic that we've been working with local authorities on, in particular, for a number of years. As you know, there has been some additional provision in terms of a particular bus that goes to the Grange every 45 minutes. But as you said, depending on where you live, you know, how easy is it to get to a connecting bus to that point?
Well, I live in Evervale, so
yeah.
I would have to get to...
Yeah, we're particularly concerned about, you know, the Blaenau Gwent, North Caerphilly type areas in particular. So one of the things we've looked at is community transport, and there was a number of pilots that were going on there in terms of looking, you know, so there's local community provision, volunteers, to how we can support people who haven't got their own transport provision. So we can get you an update on the latest position on that, because the last I heard those pilots were underway. In terms of your comment as well about a shuttle bus, we did start running a shuttle bus in the early months of the Grange opening for staff in particular, because we obviously had some staff groups who didn't have transport. We had quite a number of overseas nurses, for example, who'd come over. None of those had a transport provision. So we did start putting on shuttle buses, but we got to a point after about 3 months where they were hardly used at all. And therefore we took a decision to stand them down because they were, or maybe just go to taxis, and we offered a taxi service then by exception, rather than running, you know, some of them are coaches sitting there and we might get 2 people on the bus. So we've done some pilot around staff, but it is something we've considered for the public as well, and therefore have been keeping an eye on things through the community transport pilots. I'm not sure, Kath, if you're aware of any more issues, but I'll get an update on those pilots, Julie, and get something sent to you through Amy, if that's well. I'll send it to the rest of the group.
Okay, thank you very much.
Thank you.
Okay, thank you, Nick. Okay, we're more or less at the end of our time. We'll just ask our experts, can we try and get through a few more questions in the next 5 minutes? Can I ask that of you, if that's okay? Okay, thank you very much. We'll be as quick as we can. Please do note, though, that after this session, any questions that you don't feel have been answered, or anything that you'd like to ask extra to the answer that you've been given, you can email the email address that you used to book onto this session, which is abb.engagement@wales.nhs.uk. I'll repeat that again at the end before we sign off. But okay, we'll get through as many questions as we can. So Michelle has asked, does volunteering feature in your 12-month plan? And if so, do you anticipate a need for your volunteer numbers to increase?
Okay, does anyone else want to take that, or shall I?
Well,
I can pick it up broadly. So yeah, we've our patient-centred care team, led by Tanya Strange, very much leads on the volunteering service. And yes, volunteering is a strong feature of our plans. It's been a strong feature of our plans, particularly in the last 6 months, and throughout COVID, recognising though there were some restrictions. So we are using volunteers across our hospital settings. We are using volunteers, particularly with some of the loneliness issues and people who are suffering from isolation. And we are trying to enhance that volunteering agenda in particular as we go forward. There has been a paper recently produced on the progress we've made around this area, so I will get that, conscious of time, I will get that circulated amongst those on the call for you to see some of those volunteering activities and the plans for the future.
Okay, thank you, Nick. And on behalf of the Health Board, I'd just like to thank each and every one of our volunteers. I know they play a massive part in helping us to deliver the very best care to patients, so massive thanks to them. Dawn has asked, are there any plans in place to employ more specialist learning disability liaison nurses in hospitals across Gwent?
I noticed there's quite a number of learning disability queries, so what we'll do is capture those together, Amy, if that's okay, and we'll make sure there's this, a response submitted, because I personally don't have the details to some of those questions, but we can make sure they are answered very quickly, I'm sure.
Yeah, that's fine, thank you.
Okay, thank you very much. We've had a message from Sarah as well. It's not particularly a question, but she's asked, you can see there in the comments, anybody who'd like to share views on cancer pathways to email her as she's doing some research. So you'd like to just drawing your attention to that message if anyone would like to get in touch with Sarah. Marion's asked, can we put the plan for Neville Hall on the public page and what is being done about the workforce issues? Yeah, we put all the latest news and developments on our website, so please have a look out for that. But I think, Amy, we can also probably pick that up in the questions afterwards as well, if anyone has any further questions on that. I can see Amy's put the engagement email address in the chat as well, which is really useful. That's the email address to use if you'd like to ask any further questions. You might think of something tomorrow or even in a week or two's time. You're still welcome to ask those questions. I think we've got through all the questions in the chat by now, but I can see that Richard, Councillor Richard Overton, has got his hand up. Richard, would you like to come in with a question? I think you're still muted, Richard, if you'd like to unmute yourself.
Yes, good question.
The same problem that I had earlier. I was just saying it's the same problem I had earlier. With
the Profiles Health Communities Scrutiny Committee. The question I should like to ask is, there are parts of the Royal Gwent estates that are 120 years old. Will these now be decommissioned, demolished, and could car parking at the site be increased if there are demolitions of buildings?
Yeah, thank you, Richard. Really important points. And at one point, some of our Royal Gwent plans involved possibly decommissioning the old B block. But when we've done further work, the logistics of trying to demolish that building in amongst the site is quite complex and tricky. And one of the plans that we've done is to look at how we can invest in B block and improve it to possibly allow us to look at the old parts of St Woolas Hospital and is that a better use of being able to try to maximise the Royal Gwent site? So lots of these discussions are still ongoing. We are revisiting them at the minute in the context of making sure we make the most of those sites in the context of the COVID recovery as well. And absolutely, how do we create improved car parking provision on the Royal Gwent site in particular, also looking at the buildings that are around the main hospital, which are some of those are used for offices, some of them are boarded up. So how do we make the most of all of those? There is a significant investment we know we're going to need, and we've had some conversations with Welsh Government on this for both the Royal Gwent and Neville Hall in terms of infrastructure. This will be just in terms of some of the electrics, some of the windows. We've spent quite a significant amount of money on the lift replacement programme recently. So our plan is to put this into a bid into Welsh Government to help us resolve some of the infrastructure and then make sure we use the site as effectively as possible, looking at the Gwent and St Willows, and how we then create better car parking provision between those two sites as well. So all that work is kind of in train at the minute, and we are refreshing it now in the context of have we got this right given the new challenges we've now got going ahead as well. But very, very valid points and really important now in our future plans. Watch this space, I suppose.
Thank you, Nicola. Richard, to answer your question, I can see your hand still up.
I'm still over it now, but it does answer.
Okay, no problem. It's a little bit of a bad line, but if you'd like to ask anything else, same goes for everybody. Please do email that email address, abb.engagement@wales.nhs.uk. I'll ask my colleague Amy to write that into the chat bar again, just so you've got it right at the end of the chat as well. Thank you so much for all your questions. It's really important that that we can continue to engage with you despite the difficulties presented by the pandemic. So thanks very much for all your questions. Thank you very much to Chris and Nicola and Kath for coming on here and answering those questions. As I said before, if you have any more, please do send them to that address. Doesn't have to be the next day or so. It can be in 3-4 weeks time if you like. And if you found this session useful, please do give us that feedback and we will look at holding other sessions again. Similarly, if there's any other topics that you'd like to particularly talk about, then please do let us know about that as well. Thank you for everyone. Thanks for your kind comments in the chat bar as well. I can see lots of people thanking the experts, saying lots of good information, very informative. So some really nice feedback there from you, which we do really appreciate. So thank you all very much for your time.
Thanks, James.
Thank you all. Take care and see you next time.
Thanks, everybody. Bye-bye.
Bye.